with that, it is my pleasure and my honor to introduce our keynote speaker, Susan Phillips. Hi, Susan.
Good morning, Yvette.
So Susan was appointed Deputy Director for the California Healthcare Delivery Systems in April of 2021. Susan is responsible for the development and promotion of and promotion and implementation of healthcare delivery systems to about 13 million beneficiaries in the Medi-Cal program. And she provides direct management of 3 divisions, the Integrated Systems of Care Division, the Managed Care Operation, and the Managed Care Quality and Monitoring Division. She works collaboratively with other deputy directors in administering the Medi-Cal total budget. If you would like to know more about the remarkable work of Susan and what she's done before joining the department, please check out her bio under the Speakers tab on the Hoover platform. Welcome, Susan, and thank you so much for sharing your time with us for the next 20 minutes or so.
Thank you so much for having me. It's really a pleasure to be here.
Yeah, thank you. So I'd like to start off by asking you about the fact that the Department of Healthcare Services has launched many exciting initiatives, right, to transform the health care delivery system in California. And it aims to reduce kind of fragmentation and provide more comprehensive care and address some of the long-standing health disparities that we've been learning more and more about. How do you see these initiatives improving care for children with special health care needs, including those enrolled in CCS? And if I could ask the second question, how can families play a role in shaping these initiatives, especially families of children and youth from a broad spectrum of cultural and linguistic groups?
Thanks, Yvette. First, let me just say that I'm really delighted to be here on behalf of the Department of Healthcare Services. As you mentioned, Yvette, I have joined the department about 6 months ago, and it's both been a humbling and exciting experience. Humbling because I've spent quite a number of years in the healthcare sector with the federal government and states in different roles, and at DHCS, I'm keenly aware how much there is to learn, especially from you all, from our families, from our advocates, and our stakeholders. So again, I just want to reiterate that your voices at the table is so important for us to hear. And again, it's been exciting because as you mentioned, we are launching some big, bold initiatives. It's really a transformative time for us. So I'm personally very excited to join DHCS at the time, but we've got a lot of work to do ahead of us. So let me launch into addressing your question. I'd like to highlight 3 new benefits that are going to be available, which I think are really going to make a difference for parents, infants, young children, and really impact life trajectory. So I want to talk about those 3 benefits. And then I also want to talk about CalAIM, which is a very large initiative that the department is undertaking. So in terms of the 3 new benefits, I wanted to highlight, first is it's called dyadic services. Dyadic services is a form of therapy in which an infant or young child and parent are treated together. And so the idea is that a clinician is present or nearby with the parent and child, and then coaches the parent to really encourage that positive interaction. It could help with parenting and bonding, and really that that parent-child relationship. It could help with child behavior. So this is a benefit that'll be available by next July of 2022. We believe this new benefit will really have an impact on many lives and really support young families that really need it. So the second, California is going to be extending the postpartum care period for pregnant individuals, and this will start as of April 1 of 2022. So, you know, this benefit is going to allow for more coverage, you know, full scope benefits for individuals during their pregnancy and again after delivery. So right now they currently it's only 60 days postpartum, but now the postpartum period will be for a full year. So adding, you know, 10 months there. And so, you know, we really believe that this is going to have an impact, you know, on parents and child's life. You know, for example, you know, we know like there's so much undiagnosed postpartum care, postpartum depression. And so, you know, we believe that if we can improve access, you know, during that crucial time, we can help perhaps better diagnose and then better treat postpartum depression as an example. And then, you know, the other benefit I wanted to highlight is doula services. So Doula Services is going to be added to our list of preventive services. I'm really excited about this. You know, there's lots of evidence to show that doula services can really provide that personal support to women and families during pregnancy and childbirth, and again, that postpartum period, and provides that emotional and physical support that's provided during pregnancy and during birth, and again, that postpartum period. You know, and I want to highlight these benefits because, you know, talked about, you know, just addressing what members' needs are and the wide needs of members. You know, not every member has the same needs. There's a lot of diversity in our population. There's lots of different needs. And so these benefits can have a real impact, I believe, in addressing healthcare disparities and improving equity, including for our Black women who, you know, evidence shows that has disproportionately worse maternal and child health outcomes on average. So I'm excited about these benefits and I wanted to highlight that.
Yeah, wonderful, wonderful. Yeah, I think particularly as we're learning more about, you know, trauma and kind of ACEs for children and youth with special healthcare needs and their families, and the impact of those health disparities. These three programs, these three initiatives are really going to chip away at those inequities. So thank you. Mm-hmm. My next question was, what is Director Bass's vision for the population-based public health programs at the HCS, like CCS, CHDP, healthcare program for children in foster care? How do they fit the larger goals for the department and the administration?
Sure, yeah. So Director Michelle Bass just joined the department a couple of months ago now, and we're really lucky to have her experience and passion for children and families, and, you know, and her experience. So I won't speak exactly for her, but I will talk about, you know, what I know to be her vision and the department's goals, which are very well, of course, aligned with the administration. And so that kind of goes back to CalAIM, which I mentioned before. And CalAIM is an acronym. We use a lot of acronyms, unfortunately, but the acronym stands for California Advancing and Innovating Medi-Cal, so CalAIM. And this is really our big, bold initiative to transform Medi-Cal to create a new and better system to help individuals better coordinate care and really expand services so there's easier access. And you know, the way in which we want to design a new Medi-Cal system is that it would again be designed to improve people's health and life trajectory. There are three goals of CalAIM, which I do think are really worth mentioning. First, we want to take a whole person care approach, instead of, treating individual diseases or conditions, we're looking at the person as a whole person and trying to take that whole person care approach. We also need to be addressing social determinants of health, which includes all the social services and understand where people live, work, where they meet, where they play. All of that is an important part of our overall health and well-being. And then, so CalAIM also is looking to make a consistent and streamlined system for our beneficiaries, our providers, our plans, which are a big partner in our system, and really try to reduce that complexity. And ultimately, of course, we're trying to drive quality and equity through sustainable delivery system transformation. These are not going to be easy. CalAIM really, it's a long-term commitment. And, we know it's going to take, 5-7 years to fully implement. But again, this is California's commitment to really moving towards a healthier society. So I did want to mention a couple of initiatives there. One is called Enhanced Care Management, which is actually a new benefit that will be offered through managed care. It's a comprehensive care management benefit that really seeks to address clinical needs, but also non-clinical needs. The idea is that it's interdisciplinary, it's high touch, it's person-centered. The idea is that, it's not just someone picking up the phone and calling you, and checking in. And the idea, which can happen, of course, but the idea is that it's in person, you're meeting the member where they live, where they seek care, where they prefer to access services. And the idea is, an individual that needs that enhanced care management would have a dedicated care manager to help them coordinate care for those members across physical or behavioral healthcare. And it's going to be available. It's going to be a phased-in process, and it's going to be available for specific populations of focus. So the benefit will be available by July of 2023 for children and youth that have complex needs and conditions. So this includes children in child welfare, and again, children and youth that have complex needs and conditions. So we are launching other populations a little earlier, so we're looking to learn from that. And then in early 2022, we're really looking to have a stakeholder engagement process where we're looking to, develop eligibility criteria. What do we need to do to really outreach and engage and really set those, expectations of what the managed care plans will really do for this population of focus for our children and youth that have complex conditions. So, so that is something that we want to launch early 2022. So I'll say stay tuned for that. Please check back in with us. And I do also want to mention a very important aspect in terms of, Director Bass's goals. One area has to do with children and youth in foster care. We are under CalAIM, we're looking to develop a long-term plan for how children and youth in foster care receive health care and social services, so physical, mental health care, substance use services, social services, and, in collaboration with the Department of Social Services. So, we're working together. We've convened work groups, and we've, have a set of guiding principles and through the work group process, we have some input on how to improve the current system of care. Right now, we're working on a foster care model of care that really seeks to ensure that children and youth have that continuity of care, right? We know that's the biggest problem, kids, especially when they're placed out of home, and when they're moving from county to county, it's a time of high risk, and we don't want these kids to fall through their cracks. So we're really thinking about how to ensure they have that continuity of care and that the system is accountable for them. And I think that's a key theme that you'll hear also from our other DHCS speakers that'll be participating in the conference, that we are really thinking about accountability. And I know Director Bass is really thinking about that as well, and that's a key priority. Just again, for the foster kids, we do know that children, youth, and foster care have so many high complex conditions with their history of trauma, poor access, historically, to services, especially prior to entering the system, and and we need to do a better job there. Yeah. So please stay tuned for that as well.
That's wonderful to hear that you're focused. I mentioned I had 3 children, all of them adopted from foster care. My youngest, with his rare genetic condition, had a lot of, he used hospitals a lot, and that continuity of care is really important. And also, we have a kind of question in the chat that is adjacent to that. Thinking about, I know when he was transitioning to adult services, he was still seeing a pediatrician in an office with babies when he was 17. And it was kind of uncomfortable for him, right? Because, and so, that transition time and the ability to get to an adult care provider, especially for children who have more complicated needs, a lot of that is still, not working as well as we'd like it to, right? And so we hope that some of the initiatives that you have can also, that the department has, can also move in that direction to help that. And then there's the idea of the docs, having the ability to have that broad, those specialists available, those broad specialists.
Absolutely. That's a big part of addressing complex needs, right? Having the access to the specialist. So I definitely think those are extremely important points, ensuring that, our children have access to the right specialists that can meet their specific needs. And, we are also thinking about former fostering, right? So ensuring that after that there is that continuity of care. So because, as you very well know, that's a very difficult time. And again, just because your age is a certain age doesn't mean you can now stand on your own 2 feet. Yeah.
Yes.
So we know that. And so we want to make sure that our system does support.
Well, you definitely have lots of families, parents, loved ones, caregivers who, can be available to help the department, Family Voices, I'm sure, our leadership program, which we have a moderator coming up from. We're always available to the department to help kind of tease out those tangles and those difficulties. Thank you so much.
Thank you very much. We'll definitely be taking you up on that offer. So thank you very much.
Yeah. And we really appreciate all of the initiatives that are coming down the line and the attention to those who most need the help and who can't access healthcare without your help. So thank you so much.
Thank you very much. Thank you.
So I just want to bring in and introduce our next plenary session on behavioral health and children and youth with special health need challenges and opportunities. If I can have Ann Hall step forward, Anne is a Family Voices of California Project Leadership graduate, and she serves on the Family Voices of California Advisory Committee. To learn more about Anne, please visit her bio on the Speakers tab within Whova. Anne.
Thank you, Yvette. It is a pleasure to be here, although it is so different than how it normally is for me, having been in person a few times. When I'm struggling with travel and my daughter and all kinds of stuff, it's just amazing that this is happening this way, and I feel very grateful. I am going to attempt to share my screen here, which of course we've done 1,000 times. And from beginning. Okay, Yvette, can I get a thumbs up if you can see my screen? Perfect. Okay. So welcome everybody as we transition to our first panel in this virtual health summit. In my day job, I work for the Federal Reserve Bank of San Francisco. So I get to take a moment and sound like a Fed president and say the disclaimer that the views expressed here are mine alone and do not necessarily reflect those of anyone else in the Federal Reserve System. Just as a reminder from what Yvette told us, that we will be taking the Q&A for the questions to try to help bring to our panelists in real time. But please chat away as you're waking up, hopefully having some coffee or multitasking. I know some of us have probably been up early with our kiddos that maybe wake up early, but please chat if you feel like you can. In general, we're going to hold the bulk of the Q&A time for the end, but if there's clarifying questions like acronyms or things like that, please put it in and we'll try to bring those up to keep everybody on the same page. And if there's, I will apologize in advance if we don't get to a burning question. I know how frustrating that can feel as an attendee. If there's a lot of questions on a topic, that will help us see the need for a single topic webinar in the future. And all of our panelists have said that they will be happy to answer questions in writing afterward that we send them. If you have a specific issue facing your child or family, which most of us do, please try to generalize it as best as possible so we can consider systemic issues for general discussion. These sessions are being recorded, so we also want to try and consider respect for privacy and personal information. So now let's get started with a few poll questions. I think I will be able to see this, but if we have tech to bring up those responses, and I love that it prompted people to do that when they first came in. The first question was, what matches your reason for joining today? And it looks like we have the majority, by just a slim margin, is engaged in advocacy policy work for your profession, 53 out of 115, but very close is parent or caregiver with 40, healthcare provider 26, and then someone with specialized healthcare needs 7 out of 115, and then that one in Spanish. So good, we have actually a really good mix. The second question had to do with if you've been to the Health Summit before, and we have a lot of first timers, which is wonderful. And then we also have some that have been in person quite a bit. And the last one, if I'm interpreting these incorrectly on my phone, Holly, jump in. The last one had to do with, specifically for behavioral health, mental health. What are some of your biggest challenges? And it looks like finding providers is far and away moving up that chart, but scheduling and wait time and insurance coverage is pretty darn close. Working with the family member to try the treatment. So finding providers, it looks like, is the biggest takeaway, but then the others are tough too. And so I just want to say, while grateful to have this virtual opportunity, I'll acknowledge that my sadness that we're not meeting in person, as tough as it can be. The Health Summit and Ledge Day have become a big part of my advocacy life and a treasured opportunity to connect with others. So here's some images from 2019. And I encourage new attendees this year to consider coming in person when that becomes possible. It's great to have so many people here though, and hopefully we can continue an online option in parallel with enough sponsor support maybe. As I was preparing for today, I went back and looked at my planned remarks for March of 2020 that I never gave, and it just feels like so long ago. But if you recall, 2020 was the 100th anniversary of the ratification of the 19th Amendment, giving women the right to vote. So one of my grandmothers was born when it was illegal for women to vote. I selected an analogy from this time period that not only ties to behavioral health, but it reminded me that things can and do change around parity and what is assumed. So in this long battle for suffrage, a slogan and concept became part of the dialogue: bread for all and roses too. And I've heard variations of this before, and I honestly thought it was a bit simple. But here I found a little more context. If you will, try to look past the generalization around gender and focus on these larger concepts. The idea of all individuals having entitlement to home, shelter, and security is the bread, and entitlement to these other elements: music, learning. Bread sustains life, but beauty, the rose, gives it meaning. I'd like to further this idea a little, that bread is like our physical healthcare, and roses are like our behavioral healthcare. In my own advocating and search for services, I have found it common to have behavioral health care dismissed like flowers as a luxury or a less important afterthought. I feel like these past 21 pandemic months have shown that even for those fortunate enough to have the bread, the roses are critical for coping and connection. And here's a picture of my daughter to represent the bread and the roses. There she is with her grandpa. And she had a big fit right before this picture was taken. I will add, that's why she's all dusty. So my daughter was born with chronic health conditions and spent weeks in the NICU having a number of surgeries to save her life. She still has health issues that we monitor and attempt to control and are sometimes surprised by. My daughter also has a number of cognitive and communication impairments, and that leads us to the behavioral and mental health realm. I find the supports for her mental health to be harder to identify, to justify, to navigate, and to access. And my son has learning disabilities and some behavioral diagnoses, and now we're starting to navigate the higher stakes around adolescence. So for both kids, I'm always concerned about a next shoe to drop, or what else they may turn to for comfort and coping someday. Physical issues are truly scary and draining to deal with in one way. Behavioral health issues wear me out in a different way and leave me feeling in despair at times. It's like a dark cloud looming either in the background or maybe on the horizon. Many of the conditions our kiddos may be diagnosed with have comorbidities to mental health challenges. There's often stress and trauma and frustration with atypical or splintered development. While often invisible, we of course know mental health issues severely impact their lives, the lives of those around them, and the health of their communities. An obvious truth worth reminding ourselves is that healthcare, systems to care for our health, rarely fully address the bigger picture of total health, although it was super exciting of what we were hearing in the keynote, I will say, and what we're going to hear from our presenters. That the health of individuals, families, and communities is that bigger picture. So this is where we were at, and then the pandemic hit. In terms of individual resilience and well-being, so many risk factors were amplified and so many protective factors just had the rug pulled out from under them. I won't even try to represent or reflect the different experiences we've all had these past 21 months. I will say that I felt and feel still such intense emotions. Ever present is deep concern for the safety and well-being of my children, with magnified fear for my daughter with specialized medical conditions. There were so many critical, competing priorities. I found myself and still find myself trying desperately to help my kids and feeling like I was falling short and not doing enough. I saw these lovely images of parents engaging with kids around schoolwork or playing board games, and I truly hope some of you had moments like this. I had a few good moments, but others were full of frustration like this. In his yearbook question, my son reflected on distance education, said, so much yelling. And of course, he wasn't talking about his teachers. Struggling with completely inappropriate education for my particular kiddos, questioning how much to fight and what to let go of around appropriate education and safety concerns, because it just wasn't realistic or because I just didn't have the energy at that moment. And sometimes feeling a need to escape and not deal with what was happening around me. Yes, that's probably me playing Disney emoji blitz in the middle of that picture while my kids are doing crazy stuff. I also felt guilty pushing my kids to do what they should do for schoolwork or for healthy choices when I didn't do what I should as the adult sometimes. And now I find myself still at a loss for what the pandemic's lingering mental health impacts are and will be. On top of the before worry, I struggle with what my kids are showing me and able to express and what they may be hiding or understandably don't even know themselves around their mental health. There sadly is still so much yelling that I'm trying to work on. I came across an image that in some ways reminds me of that iceberg image with a COVID twist on what we see versus what's present but not visible. And some of you may have seen this already. Here's this very polished woman, maybe engaging in a work happy hour or an online date. And then we see a fuller picture. And there are just so many details to appreciate and relate to here. And no judgment. I think about a version of this with me or my kids. What do they show me and what do they struggle with? With the acknowledgement that the pandemic has brought so much trauma and need, it has also brought the topic of mental health more to the forefront. It has blown apart the myth that we can separate mental health and physical health as two distinct things with clear boundaries of care. The bread and the roses are intertwined. My last slide is to plant the seed of a definition for mental health with language I find simple, approachable, and yet sometimes so aspirational. I really think about my kids and truly myself when I read this definition from the World Health Organization. Mental health is defined as a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. With that in our minds, I will introduce and turn it over to our first panelist. Jim Kooler serves as the Assistant Deputy Director of Behavioral Health at the California Department of Healthcare Services, or DHCS, as we've already heard. In this role, he's responsible for leading the policy efforts to see that youth receive the behavioral health services they need. And I encourage you to look at his bio as well as all the others that I'll be introducing in turn. So I'm going to hopefully stop sharing. There we go. And Jim can take over.
And well, thank you so much. I think your words, your heart are exactly what the participants of this conference are looking for. I'm afraid that what I have to offer is probably too governmental and maybe a little dry, whereas yours brings the heart to action. So thank you for the opportunity. Thank you to Deputy Director Susan Phillip for setting the stage on CalAIM, probably our biggest change and the way in which the world is evolving. And my hope is that what we can do is take a look at just a couple other initiatives that we are working on as we move through here. But as we begin, I'd first like to welcome you to the AFZ. And you're wondering to yourself, well, Jim, what is the AFZ? Well, as was noted earlier, what we're trying to do is create, yes, an acronym-free zone. So throughout the presentation, we hope that each of us as presenters will minimize our use of acronyms, or if we're using it, at least describe what it is before we go much further. And I do want to figure out before we're done the Disney image blitz. I don't know that one, but I think I probably need to start that. And as you talk about,
Don't. It is so
it's
addicting.
addictive. Okay.
For any
Well,
of you that play it, Coco just came out today and it's waiting for me.
well, you're off screen. You can dabble in it as we begin. But your analogy about bread and roses in California, maybe it's bread and poppies. That we take a look at what's growing in California that's unique to California. And as we think about what we're doing, 3 E's that might make it helpful for us. We're trying to make things easier. We're trying to make sure that they're equitable, and we're trying to make sure that they're effective. So if we can have those 3 E's riding through what we're trying to do, we may be more successful. So one thing that I will focus on here is our Child and Youth Behavioral Health Initiative. And it is a $4 billion investment over the next 5 years. And our goal is to really transform the way in which we take a look at children and youth behavioral health services and make sure that California is leading the world in looking upstream, that creating a system where every child and young adult gets screening, gets the support, and looks to move to address issues earlier instead of waiting until they are severe. So really an evolution of our system from really treating disease to trying to prevent it. And as we do that, the Children and Youth Initiative is again taking a look at how can we take the opportunity of a lifetime here and use these $4 billion to change our service system. Taking a look at using technology in a way that we've never used it before. Thinking about ways in which we can provide services to everyone to try and give them the opportunity not to need services at a higher level. So using a virtual platform that could do some assessments and do some referrals and help get young people into systems and to supports that they can help themselves first, families can help themselves first, and then go to higher levels of need as are necessary. As we take a look at why would we want to do something like that? Well, we know that mental illness generally can be diagnosed and begins by the age of 14, and that most people who have those kinds of challenges begin by the age of 25. So we'd like to intervene early. And our system today is inadequate, that there's too little focus on prevention, there's not enough programs, there's not enough workforce, that there aren't enough crisis services available, and there are too few opportunities for inpatient. So there's a lot of shortcomings, but the most important issue is that these issues are based in communities of color, and they're inequitably distributed amongst low-income communities, LGBTQ communities, and where ACEs, adverse childhood experiences, are exceptionally high. So we want to take a look at some of the key components that the state will be investing in over the next 4 years. We mentioned briefly the portal, behavioral health virtual platform that will have a network of programs underneath it, and then taking a look at providing training to those professionals who will be engaging with young people, taking a look at schools, because we know if you're looking for young people, schools is probably a good place to look, and that making sure that schools are good partners in behavioral health and that they have the capacity that they need to deliver services, that we're using evidence-based programs, that we have a continuum of care, and that our infrastructure supports that. And the dyadic services that Susan spoke about, making sure that we're connecting behavioral health or BH services with medical services, taking a look at how do we expand our workforce, and that there's a public education campaign that will change people's perception about behavioral health. So maybe it's bread and poppies. We got a new theme we hadn't thought about. But trying to change the stigma around behavioral health issues, and some of that is happening in our culture all around us. When you see world-class athletes stepping out of competitions because they don't feel right, That makes it easier for all of us to change the behavior that we have. So as we then take a look at our next area, those key components of our virtual services platform. This is going to take us several years to put in place. So it's a multi-year effort of really using subject matter experts, using artificial intelligence, and trying to figure out how to create a statewide platform for all those up to the age of 25 that creates a tiered model of support that young people can step in at age-appropriate levels, get some services, get consultations, and then get referred to the right level of service if they need more than what is available through that portal. That we'll be using evidence-based practices, that again, we're going to be focusing on schools and providing grants to schools and to managed care plans to see if we can't get those two worlds to work more closely together, and also looking at expanding our workforce. We also want to take a look at the infrastructure around beds and facilities, because if you do all the referrals and someone needs it and there isn't a place to go, we haven't really provided that kind of service that we should be. Then also taking a look at those dyadic services, that it may be that the child is the one who is covered for services, but being able to provide a dyadic service allows us to work with the family and the parents as well and give them the support that they might need. And again, the education campaign, and with a $4 billion investment, we really ought to be measuring what we are doing. So making sure that there's an evaluation component built into that. Those are a lot of linear things. So sometimes a graphic makes it a little bit easier to take a look at. And that 2024 launch of the platform is when we anticipate it really going live, though there may be pieces that we will be able to put in place sooner. But it is an ecosystem of all these things working together that we hope will provide an evolutionary change that is almost a revolution in behavioral health on the way in which we can provide services. So that gives you a real quick overview of the Children and Youth Behavioral Health Initiative. And there are a few other things that our department is involved in, and some of them are actually off the screen, so you won't be able to see those. But the first of those is the peer certification process, trying to make sure that we are engaging peer level people to provide support as they have been, but finally honoring them by being able to reimburse and to be able to fund them at a level that makes sense. As was mentioned by Susan, the foster care model of care program, making sure that we take a look at those young people, children and youth who are in the care of the state, and providing them the kind of services that they need and not having them continuing to fall between the cracks. We're also taking a look at 988. And if you're not familiar with the 988, you will be, because come July of next year, there will be a new phone number available so that if there is someone who has a behavioral health crisis, instead of calling 911 and get primarily a law enforcement response, you'll be able to get a behavioral health response. So we're very excited about what 988 could bring to our system. There's also, you may have seen CalHope, and CalHope has been our crisis counseling program funded by FEMA, the Federal Emergency Management Agency, and SAMHSA, the Substance Abuse Mental Health Services Administration, to provide California the temporary resources to provide Californians the behavioral health supports to address the stress and anxiety we've all been feeling. If you go to calhope.org, you'll find a number of resources, and particularly encourage you to click on the Together for Wellness site. And that we created to be unlike most state websites, which are wonderfully long lists of blue links that take you somewhere, but you don't know exactly which one you should choose. Together for Wellness is a much more human-centered website that can help guide you and support you in finding the things with the use of videos, a much more supportive environment. And finally, Angst Building Resilience is a program available now to schools across the state of California to engage young people and parents in the discussion about the stress and anxiety that we're all feeling. So there is a whirlwind tour of all of the, at least not all of, but many of the assets that we're working on. I believe that Kim, who will speak next, will be talking about some of the other resources that we have available. So Anne, thank you for the opportunity to be a part of this discussion, and thank you for allowing the Department of Healthcare Services to be here with you today.
Oh, you're welcome. I will say, Jim, I saw your slides ahead of time. It was a little overwhelming. You added a lot of the human voice and color. I'm just going to pause to see if anyone has any technical questions, things that they just really didn't quite understand in terms of concepts before we transition. I'm not seeing any that are specific to just sort of these things. Holly, jump in if I'm missing it. And so I think we'll go ahead then and move on to our next speaker, who is really going to amplify a lot of these things. And then I promise we also have something specific to schools coming up after that with Cheryl, because I already see some school things coming in, which does not surprise me. So Kim Lewis of the National Health Law Program is the managing attorney of the Los Angeles office. She works on state and national healthcare issues, including Medicaid and health reform implementation. And again, I encourage you to look at her bio with tons more information. And she's always really super available to our attendees if they have questions or anything like that. So keep that in mind.
Great. Hoping you can hear me, Anne.
Yep.
Just give me okay, great. And you can see my screen. I want to make sure I'm sharing.
Sure can.
Great. Thank you so much, Anne. And thank you for really the way you brought this sort of conference open session into reality. I think we've all been experiencing a lot of challenges over the last year and a half, and no more than people who are at this conference and the families and caregivers who have been taking care of children and youth with special needs who have struggled the most through this process, not being able to be in school, not getting the services they need. And I'm really hopeful that today and the day when the CDC has approved vaccines for 5 to 11-year-olds, that we will be on our way to hopefully a better next year, and that we'll be able to have this conference in person again, so that I can see all those amazing families out there in the audience and talk to them about their experience and how we can be more helpful. So I'm looking forward to that, and I'm hoping that the Zoom world of internet instability, dogs, blowers outside is going to be a thing of the past, although I'm not going to hold my breath that will last forever. So just sort of elaborate on some things that I think were talked about earlier. And let me just quickly introduce where I am from, if you don't know. So the National Health Law Program is a nonprofit legal organization that works to essentially advance the healthcare rights of low-income and underserved populations across the United States. So we really work with all states and advocates in a whole, really in every state. But we have 3 offices in Washington, D.C., Los Angeles, where I am, and North Carolina as well. So just wanted to give you that background. So the roadmap today, I'm going to talk a little bit more about what I think you heard a little bit about earlier from Susan Phillips at the Department of Healthcare Services, and that's kind of some more of the behavioral health specifics of what we call CalAIM, which is California Advancing and Innovating Medi-Cal. But before I do that, I'm just going to quickly sort of ground people in really where we are today in our system and why it is so complicated for families to navigate. And so it isn't that you aren't smart enough or capable enough to understand it. It is that the system is really designed in a way that is not friendly to families and to children and youth, or advocates for that matter. So it's not that you're alone in your confusion. So I want to make people aware of that and know that this is a daunting system to navigate generally. So, let's talk a little bit more about Medi-Cal behavioral health delivery system. But I think, before I just show you a slide that highlights for me the daunting nature of a bifurcated or trifurcated, which is sort of 3 different systems you have to navigate for behavioral health services in Medi-Cal. I just want to remind people that Medi-Cal is the biggest program, really healthcare program in the state. 13.6 million children, families, older adults rely on this program to get their healthcare. Of them are children and youth 21. So it's a lot of children and youth who depend on this system to work for them to get their needs met. 84% of them are in managed care. So when I show you this, that shows you the different managed care. Understand that most and families are dealing with managed care now. And I see my internet is unstable, so hopefully you can hear me.
Yeah,
So-
we can hear you, Kim. You're still on your overview slide if that's what you want to be on.
Yeah, I'm moving on here.
Okay.
So here is the slide that I referenced earlier to just have an appreciation for system is trifurcated. So you've got Medi-Cal managed care plans, which I mentioned 84% of people in Medi-Cal are on. Then you've got county mental health plans, which are the specialty mental health system that children and adults deal with when they're moving to a what might be considered a more high-end need in the system for behavioral health services. And then there's the county drug and alcohol programs, which is yet a third system. So if you need substance use disorder services, drug and alcohol services, you're going to be dealing with yet a different program in the county. So imagine families trying to understand how to get into the system and where to go. It is quite challenging, as you might imagine. But there is some good news on the horizon, and it's not that we're getting rid of these boxes. That would be my goal, but at least there will be some effort to try to simplify or at least make those bridges between these systems work a little better. And before I kind of go on to the next slide, I just want to highlight a couple of services that were not spoken about specifically previously, and that is that the Medi-Cal managed care plans do now cover family therapy services, which is a new benefit in managed care. It is available today, and it really provides an opportunity for therapy for a parent and a child or 2 family members, that's a minimum, to be able to get behavioral health services and specifically family therapy when either the child has been diagnosed with a mental health condition or it has risk factors that make them put them at risk for having a condition like trauma or a parent who is absent or deceased, things that are high risk factors, or for a parent or caregiver who has high risk factors that makes them potentially a candidate to need these services with the child. So this is a new thing that I think should be considered and looked at as a family member from if you're in managed care to seek those services. And then on the alcohol and drug use services, there's a thing called assessment, brief intervention, and treatment. And those, it's called ASPR. We don't like to use a SABRT, but that's the name of it. So formerly that was alcohol only services for members 11 and over, but now it's also for drug use prevention and brief treatment as well. So if you're not already in the county mental health system or the county alcohol and drug system, you can get some brief services from your managed care plan. So just a quick reminder in this slide around the term that I know is a mouthful: early and periodic screening, diagnostic, and treatment services, or EPSDT. I know I did not make up that term. It is in the federal law. So it gets confusing, I understand, but it is a really, really important legal entitlement for children and youth. It means that your kids or families can get services. They're entitled to services because they have Medicaid that other kids and families can't get in private insurance, that other adults in Medi-Cal can't get. And that is a really important thing. It's an entree to a lot of services in the behavioral health area that kids and families need to essentially, function and to do better and to maintain success in their homes and families. So managed care plans have to screen children for those behavioral health needs. We're not talking about that as much today, but it is an important thing to know that you always have that, they have that obligation to do that screening. And then that treatment you need or that is medically necessary to either, it says correct or ameliorate a physical, mental illness or condition is in what the law is. So that really is a very broad opportunity for getting services that are medically necessary. So it is really important to keep that as a background for understanding your Medi-Cal rights. So I'm going to talk now quickly about California Advancing and Innovating Medi-Cal, which is CalAIM. And I know that's been talked about and mentioned by both earlier as well as by Jim recently. But I'm going to go into some of the specific details of the behavioral health parts of. So the overview of that is a comprehensive kind of initiative, right, to change Medi-Cal services across the board. It relies on two sort of vehicles to do that, which are what we call waivers to the federal government to ask that services be changed or allowed to be waived in order to provide some of the things that the state is trying to do. But it is a larger delivery system effort, and it's not just in behavioral health, but it is also in Medi-Cal managed care, oral health, long-term services and supports, and other home and community-based services, justice-involved populations, those inmates or youth leaving juvenile hall or leaving county jails, and other county programs and services like the foster care model of care, one that was mentioned a couple of times. So this is a very large-scale effort. It is not a small effort. It is very, it is multi-year, as we've talked about, and it is across the board. This is the link to that page of the department's website where all of this information is contained. So I want to specifically talk about some of the behavioral health improvements and changes, and that is the standardized screening and transition tools that are going to be brought into place in 2023, clarifications related to medical necessity changes and access to behavioral services, and then other changes to improve continuity of care and ease the burden on providers, and then payment reform, which we're not going to focus on today, but that is essentially to try to allow the system to move from one that's cost-based reimbursement to one that allows for more outcomes-based, value-based purchasing of care. So that I think is really critical for managed care to do its job of focusing on outcomes that kids and families want rather than on just payment to providers for services provided. So let's just talk quickly about the first one. This is a screening, standardized screening tools have to be developed to ensure that, as those three boxes I provided at the early outset is sort of a critical to see in your mind. These screening tools help navigate which system you belong in. So the purpose of this front-end screening tool is to determine where you should refer to. Should it be in your managed care plan? Should it be in the specialty mental health system? Should it be in the drug Medi-Cal system? That's what the tool is designed to do. The tool will be an adult tool for those over age 21, and there will be a separate tool for children under age 21. So these two screening tools are intended to try to help people in the system more effectively and get to the right door. The transition tools are requiring to be used for transition between these delivery systems. So as we know, managed care plans, specialty mental health plans, and drug Medi-Cal plans do not provide the same services. So you really have to find a way to navigate between these systems and get transferred from one system to another to get what you need. So that transition tool is designed for that purpose. It's being developed by the state as a tool to help people across the system from one to another. Again, that will be for two separate transition tools, one under age 21 and one over age 21. The state can require these standardized tools be used by counties and plans, and I hope that that's what they choose to do. The second area is about aligning medical necessity. And I think this is one where, hopefully you are all very excited about, and I know that I am, which is to, ensure that they get what they need when they get to the system. The first important change is that you don't need to have a diagnosis before you can start receiving these mental health or substance use disorder services. That is really, really critical, as our systems, especially the county behavioral health system, the specialty mental health system, has required a diagnostic based on entry into the system, which did a lot of barriers to care. So this means that you will be able to get services before that diagnosis is arrived at, and we don't want kids to be prematurely labeled with diagnoses that they don't have in order to get care. The next is about the ability to receive services from multiple systems at the same time. So if you're in therapy with a therapist in your managed care plan, and you need to add some specialty mental health services that your child or family member needs, then you should be able to be in two systems at once, as long as they are not providing exactly the same thing. So there's no duplication. That's a really important thing, as people may need substance use treatment while they also need mental health treatment, while they may need healthcare treatment. And it isn't that one system is going to provide it at a time. They may need it at the same time so that they can get their needs met simultaneously. And then lastly, the clarification, as I talked about medical necessity as a federal entitlement under the federal law, this is an important area where the state is trying to clarify the compliance with that federal entitlement by making sure that the protections of that EPSDT, or early periodic screening, diagnostic, and treatment rights, are being upheld, so that they can get those services as they need them, and there aren't too narrow a front door to get in to get them. The second area I want to focus on is around the behavioral health delivery system changes, and that's a no wrong door concept. That is not yet in place, but hopefully will be, where you can show up in a system and start getting the care you need without having to be sent to a different system. Now, hopefully that screening tool will work to get you to the right door in the very first instance. However, if you start needing care, you should be able to get it where you show up and not have to keep getting moved or told to go somewhere else. That's a really important concept, and I hope that this becomes a really important embedded reality in the system, so that kids and families aren't forced to go from one door to the next being told no. And secondly, expanding access to specialty mental health services. That's that county-based system that I talked about, when they have high risk due to trauma. So there's an effort underway to end access to these specialty mental health services for children and youth experience trauma, including involvement in the child welfare system, experiencing homelessness, or having been screened for trauma, and having a score, they call it, that is high, shows a high risk. So that's an expansion, which is really important. And then finally, streamlining the documentation and auditing requirements. This isn't one that you probably care a huge amount about, but we do know that documentation is a huge barrier for providers wanting to participate in the system, and also having different rules in different counties for how they participate when they work in various counties at the same time. The important effort underway to try to improve and streamline that, as well as the auditing that happens to disallow counties or providers to bill and claim for Medi-Cal coverage services. So hopefully these are sort of administrative level changes that will improve the system. And then I don't want to spend a lot of time on this, but just to, I think, as mentioned earlier by Jim, and as well as earlier by Susan, the dyadic services are a new benefit in 2020, will be into family therapy, I already have mentioned. Behavioral health delivery system changes also coming are the peer support services, which is that peer-based kind of help in the system for kids and adults who have a need for a peer to help them navigate and work in the system, support them. We know peer models are really, really critical. So that will be coming about next year. And then contingency management is a new substance use disorder service designed for a particular population to enhance and improve and incentivize care in ways where there aren't medications to treat them. And then crisis services. There's a lot going on to try to expand crisis and mobile crisis services. To me, these are some of the most critical missing services, even though they are part of the entitlement for children that the system is not currently providing. We need to have 24/7 crisis services available for children and families at the location that they need them, where they don't have to take their children and youth to the hospital to get care. So a lot of efforts underway to try to expand that over utilizing federal dollars that are now available, utilizing some new mandates. And one of them I mentioned in this slide is the Family Urgent Response System, which is a new foster care-based crisis service system requirement that started in 2021. So there is a lot there to be excited about, and I'm hoping that we'll get more on this. School-based services will also be coming online in 2024. And I know some county providers already have relationships with those schools in school districts, but it is really very piecemeal at this point. Finally, again, something mentioned earlier, if you were on this session with Susan, enhanced care management community supports is a new benefit in managed care, will be coming online next year. For children and youth, it's going to come on in 2023, of July of 2023. But the target population for these expanded care services, a really high touch, as they call it, support for families, is going to be children with complex medical conditions, like children in California Children's Services, or children in foster care, or children with severe emotional disturbance or substance use disorders. These are part of the target group that will be needing and getting these services from managed care plans, which should really provide a much greater support and navigation for families across the system. Finally, just a few takeaways. One of the questions you need to ask is, will children with behavioral health needs have better access to care? That is the purpose of a lot of these changes, and we want this to be true. So seek and attempt to get these services and let us know how that care is being delivered. And then how will managed care plans and behavioral health plans be ready to provide these services to children with special health care needs? Will there be providers who are familiar with the population of children that we're talking about, those with California Children's Services, CCS, those with severe, serious emotional needs? We need to have the providers who know how to address and deal and serve families like this. And then how can families stay involved? So there's that CalAIM website. There are managed care plans that you can talk to in your county to find out what they are doing. There's obviously Family Voices, a very critical organization. And then there's the Health Consumer Alliance, which we are part of, that provides health consumer assistance across the state for children and families and adults through a toll-free number. I think that's where I'm going to stop sharing and see if there's any questions.
So thank you, Kim. If hopefully we'll have time, and I'd love to, I'll put this seed in our tech support, that I'd love to bring up that key takeaway slide again at the end in our Q&A, because I think that can, hopefully we'll have time for a little more amplification of some of those things. I do want to say, because it's come through a couple times, about people getting access to the question or to the slides. And so Pitmark said that, and Ali said that slides and recordings will be posted on the website after the summit, and we will send an email to all registrants when they are up. So you will be able to have access to all those details and great information. There's some really great comments that have come through, but again, please put your Q&A that you want a response to in, and we're tagging those to answer at the end. So we are monitoring that. So now I'm going to turn it over to Cheryl, who I think has a topic near and dear to lots of us that have school-aged kids. Cheryl Theis is an education advocate in the Parent Training and Information Center at DREDF, Disability Rights Education and Defense Fund, with a special focus on the intersection of disability, social justice, and education. And here's my quick pet peeve while Cheryl's getting set, that I absolutely loved the audiobook recently, Being Human by Judith Heumann, picked as a San Diego Public Library book. But in the audiobook, narrator kept saying DREDF instead of DREDF. And I had to mentally correct it every single time. I was like, no, it's DREDF, DREDF. So, which is just a fabulous organization I have used myself. And this is, I think, going to be a really terrific presentation. Go ahead, Cheryl. You're muted. Had to say it once. It's not a Zoom without reminding people they're muted.
That's because my control panel went up to the top of my screen and I'm not used to that. So sorry about that, everybody. Can you hear me okay, Anne? Just a quick sound check.
Yes.
Because as everybody knows, anything that can go wrong will go wrong. So my microphone died this morning. So I'm using, the good thing my kid likes the game because I just stole his microphone. So good morning, everybody. And thank you so much for having me. And thank you to my co-presenters for framing the issues in a way that makes it clear how significant these issues are, but also that there's a lot in the works to try to address them. And you know, it's always about progress, not perfection. And I think that's an important thing to keep in mind as we do this work going forward. So as Anne said, DREDF is, we've been around for a long time. We are a national law and policy center. We really are focused on disability, civil and human rights. Within DREDF, we have a parent training and information center, and I'm imagining many people know about the parent training and information centers, but just for some background, the parent training and information centers are available in every state and territory in the United States. And they basically came about because when the special education law, known as IDEA, was being created and the regulations were being implemented, the families and the advocacy community said, this is all great, we're going to give people a lot of rights, but it's so complex, how will they ever understand how to use them? And so part of the funding for the law included establishing parent centers where people could get free help and information about how to serve and support their children. So I just included a link in case you want to find out what service, what parent center serves your area. So what I want to talk about is really just comes straight out of the presentations you've already heard, including especially, I think, Anne, which is, you know, there's multiple complex layers here. It's really overwhelming. And we ask families to learn all of this at a time when they're often most highly stressed. And that's really, really challenging. So we know that there are laws, policies, and best practices that support children with emotional and behavioral disabilities, but it's really hard to do it effectively, and there's a lot of reasons why. We also know that we built a system of support, at least on the school side, and I think on the healthcare side as well, that assumes that every child has a parent in a traditional sense of the word, and that's simply not true. Many children have a parent who would love to be involved but can't be. Parents are challenged with barriers that cross many areas, including, you know, do you focus on school problems or do you focus on finding housing for the evening? For some families, you know, they are incarcerated or are out of the country, they've been deported, and so it's very hard to advocate for your child when you're dealing with those kinds of issues. So keep that in mind as we go forward. Another issue that I think, you know, it's just so critical right now is that we know that mental health and behavioral challenges don't just exist in one site for children, right? They're not in a silo. It's not you go to school, everything's fine, you come home and have mental health challenges, or you go to school, you have behavioral challenges, and then you go home and everything's just working fine. So these are complex systems, and the way that we've traditionally segregated them into these silos really doesn't work very well. The other personal pet peeve of mine, and I should say I have 5 children and 2 of them have had needed special education support and had behavioral challenges related to that disability, is that, you know, we all like the phrase of the decade or the year or whatever it is, and trauma informed is something we all throw around, but it's not just a label. It's a system. It's a whole new way of thinking, and it should be actual services, boots on the ground, not just something we say, yeah, we're going to do a trauma-informed behavior plan, but really thinking about what that means. Obviously, we have some new problems related to school, and I'm going to talk about them, including things like learning loss and regression for students during COVID-19 school closures, or school building closures, I should say. Questions about how we're going to repair that, make that up for children, how we're going to put them back where they were. Seen an awful lot of calls and intakes lately from parents who are struggling with issues related to children who struggled with social skills, who got more and more isolated during COVID, and who are really behind where they were. And coming back to school has been very challenging. We're also seeing increasingly parents being called to pick children up at school, or children being put back on home hospital or other home-based programs because the schools feel like they can't serve the student, and that's a big challenge. So the other final thing I just want to say is an overarching issue that keeps coming up over and over again for us is that there's an assumption, I think, on the part of a lot of the education professionals that children come to school with mental health needs, but not always a recognition that school itself can be a source of stress, anxiety, and can increase or even create mental health needs. And so when you see a child who's struggling with behavior, we shouldn't be making assumptions about, where the source of that problem is. That's what we use evaluation and data for. So let me.
Cheryl, as you go to the next slide, can you just make it the full view so we can see all the great information more easily?
Yes, absolutely. Is that better?
Perfect, thanks.
Okay, thank you. All right, so I want to start just by kind of reminding us all how far we've come. And I have the Oakland Unified School District's Community Advisory Committee for Special Education to thank and give credit to for this slide, because they used it at one of their presentations. And I just think it shows back in 1960, who was excluded from school. And it was pupils whose physical or mental disability is such as to cause attendance to be inimical to the welfare of other pupils. They could be excluded from school. And at the time, California Education Code included things like filthy or vicious habits, contagious or infectious disease, and physical or mental disability, if it is such as to cause attendance to be inimical to the welfare of other students. So, we've come a long way. At the same time, I would have to say that some of this still lives in the, sort of quietly lurks in the shadows and impacts how students are seen, especially when they're having behavior challenges at school. And it's something that, we still have some work to do in terms of understanding that these needs are just needs. We like to say that, you're not defined by your disability, and these aren't special needs, because everybody's needs are just their needs. There's nothing special about what it is that you need. So how big is the problem that we're seeing in terms of mental health at school? Prior to the pandemic, the estimate was that about 1 in 5 American children struggled with social, emotional, mental health needs at school. However, the U.S. Secretary of Education gave a talk on National Public Radio about 2 weeks ago where he said, all of the data, and I included the link, now shows that about 8 out of every 10 students has mental health needs at school. This is post-COVID and school return. So this is a huge issue, and we've seen a big increase in the number of emergency room visits, and they're often driven by schools. Children are 5150 from schools, the police or medical professionals or parents are called to come get students in a behavior emergency, and it's a really challenging problem. It's more than an individual child problem, because we know the outcomes if children and youth with emotional and behavioral needs don't get help. First, the risk of having more mental health problems down the road. We know there's a link to academic performance. So being at risk for mental health problems in the first grade leads to a 5% drop in academic performance in 2 years. We know the dropout rate for all students, this is actually a national statistic, is about 7%. For special education students, it's around 21%. For students with emotional disturbance as their eligibility category, that climbs to almost 40% risk of dropout. And we also know that dropout leads to other adverse circumstances, including juvenile hall, prison, homelessness, etc. We also know that 70% of youth who are involved in the juvenile justice system meet the criteria for a psychiatric diagnosis, and 68% of inmates in state prison haven't completed high school. So these things are related. So these are just, they're hard statistics to hear, but they're really important in creating a sense of urgency about how we do this. So children with mental health problems that aren't addressed experience all these outcomes: more discipline referrals, including suspension and expulsion. But I also have to say, more calls to parents to just come get them from school, which creates tremendous family stressors in people's jobs, people's own anxiety and stress level, and so on. We know when these needs aren't addressed that kids start to vote with their feet, by which I mean they avoid school, they have panic attacks when you take them to school, they have greater anxiety. And we know that there's just a lot of other increased risks, and yet we built a system where so many of the supports students need are sort of hardwired or hard packed into the school system, and there's some real challenges there that I want to talk about. So some of these my colleagues have already touched on, but I just want to point out that this is the feedback that we get, especially from families and from healthcare providers who often call us in our parent center at DREDF to get guidance about how to support the families that they're seeing clinically because of school problems. So first of all, educators don't get a lot of training time or professional development to understand the needs of students. Educators recently told me at a meeting I attended that generally, it's at least a week or two after school starts before they even get a chance to read a quick summary of a student with an IEP's needs. And for students with behavioral challenges, a week is a long time at a high stress period when kids are just coming back to school, especially right now. We know that there are a lot of service coordination problems. So again, this problem of silos, behavioral health, therapeutic schools, community-based services. And we also know that there's a lot of reasons why some families struggle more to participate across these complex systems. So families with limited English proficiency, families who are unhoused, families who are dealing with other kinds of barriers. So the good news is that we have so much information about how to help kids be successful at school when they have mental health or behavioral challenges, but we also know there's huge equity gaps here. So what do we do about that? Something that's very much on our radar right now at DREDF. We also know that we've built a system of special education, and I would include here also children who are supported under Section 504, which is more of a disability civil rights law, where we say things like, the child is entitled to legally, this is a legally compliant plan, but that doesn't always mean it's effective. So for example, when it comes to therapeutic relationships, one therapist is not replaceable with another. And yet we know that some of our most vulnerable youth in foster care, some of our families who are dealing with multiple challenges, are often those very children who are served by more interns, more uncredentialed teachers, the newest people fresh out of the chute, some of whom can be wonderful, but they're not dealing with they don't come with the depth of experience. So we know that that's a real concern. Right now, there are tremendous staffing shortages. There's turnover. And so a lack of stable, trusting, long-term relationships at school is a real problem. We also know that there's real concerns for students who have behavior challenges around segregation. So, what we often do is move students into programs where they can get more services, and yet they lose access to all of their typical peers and to the kind of quality academic instruction in order to get those services. So that's an ongoing issue. I think, Kim, you mentioned this, but the concerns around double dipping. So many families will call us and say, they said that I have to choose whether my child gets school-based therapy or whether we can continue to get our family therapy because we have Medi-Cal. And of course, there isn't any, there's ways around that. That's not something that should be happening, but it often is. There's often lack of programs for students who have different kinds of needs. And one of the biggest reasons for calls at DREDF goes to something that's a pet peeve of mine, which is that all behavior problems aren't necessarily acting out, right? We make assumptions that behavior means that you're acting out. Many behaviors relate to self-harm. They relate to withdrawal. So these aren't students who are necessarily acting out in the classroom or coming up on the radar of a discipline matrix, but they are having behavior challenges. They're not engaging in their learning. They're not able to even attend school or to manage their stress level and be available for learning. And yet a lot of the programs are focused on students who have externalizing behaviors, acting out, when a lot of other students who have this acting in set of challenges are overlooked or not served. And then there's a lot of concerns I'll talk about more in a minute around regression during COVID-19 school closures, and how schools can address that and how they can coordinate addressing that with the healthcare system. So there's really not good models about how to do that. And then the transition to adulthood issue, which is falling off the cliff, we call it, as students exit from the public school system and enter the adult care systems. For mental health, this is a major source of vulnerability for people, and a lack of preparation is a big problem. There's also a tremendous issue around evaluation and assessment delays over the last couple of years, and refusals. So often families are told, you need to go get proof of a diagnosis, which makes me really excited to hear about stuff Kim was just talking about. When a parent is saying, my child, you're sending them home, you're suspending them, or you're saying there's all these behavior issues at school, can I have my child evaluated? And they say, well, do they have a diagnosis? And so just to clarify, that's not required and shouldn't be happening. If there's a reason to be concerned about a child's needs and behaviors interfering with their learning, then an assessment is what should be done. There's obviously a lack of trauma-informed care, a lot of stigma concerns. And I want to stop here for a minute and just say the stigma, first of all, for children and youth themselves. So, if you build a program for a student at school where they have access to a counselor or a therapist, but when they go, they get triggered or activated, or they feel like they're sent out of class, that they're not included, or that if other people knew they needed this help, they would think poorly of them. That is a barrier. And then there's stigma for families. And I want to say here, because I assume and I hope that there's some educators here today, that whether or not it's actually happening, families are worried about things like, is someone going to call CPS and report me to child welfare? And there's different risks here for different families. So for example, our Black families worry a lot about this and often feel like they got a visit from CPS after they started pushing for their child to get more services. Whether or not that's happening, it's a serious concern for a family. The other issues are things like, maybe we're not documented, or maybe we're here trying to get a green card and we're worried this could impact immigration. So all of those things come into the picture here in ways that I think the education professionals don't always understand. They just see that the parent isn't advocating or isn't attending the meetings or whatever, and so some assumptions get made. And then finally, I'm not going to go through all of this, but the school to prison pipeline is something that we just don't talk about enough. So we know that the more we segregate students, the more we discipline students, the more that they're out of the regular educational environment, the greater the risks are for them, entering the juvenile justice system or having other kinds of poor outcomes. So I guess the biggest message that I want to leave people with today is, first of all, if you're a parent, caregiver, or a community member who's struggling with these issues, find and contact the Parent Training and Information Center in your area, because these are things where we can help you understand what to do if an assessment is denied or there's delays or you're worried about learning loss and so on. But secondly, to really emphasize how important families are as partners and how important family engagement is in this process. These aren't silos. And one thing I didn't mention before, I just want to make sure everyone understands, is that we get a fair number of calls every year, and they're often the saddest, most frustrating calls from families who say, I'm a foster parent, and if I can't get this child help for school support and behavior, I don't know that I can continue to parent them. So home placement gets impacted by school problems. Sometimes it's a family who says, my child's social emotional behavior issues are so severe that if I can't get them more help at school and a more intensive level of support and wrap services and bring my healthcare and my education team together, I'm not sure I can bring the child home. We got a call like that last week from a parent who said, I've been told my child can come home from a psychiatric hospitalization, but the school says there's going to be at least a month's delay finding a placement. And CPS has said that my child's behavior impacted their siblings to an extent that they may not be able to stay in the home, the siblings, if that child comes home without services. And the parent was sitting at with all of this, how to serve the child in crisis, how to make sure her other children could stay safely at home, how to make sure the child got appropriate access to education. And you know, this happens. We have parents who say, I cannot come pick my child up today from the hospital, and I need to involve child welfare, and they're told you're abandoning your child when they just don't feel like they have any other options. So that's still happening today, and it's something we all need to think about. So I'll stop there because I want to make sure we have time for our Q&A, and let you take back over, Anne.
Okay, and there are a couple, if you actually, Cheryl, if you want to just show, yep, we have your contact information and then tons of great resources. So again, people can have access to these slides so that they can look at them later. Those will be available.
And that includes our contact information, so thank you.
Okay, so now I feel like we're bringing everyone back onto the stage because we have a lot of questions that are so fabulous. I will do one clarifying question because that there was one about when does the 988 service that Dr. Kooler had mentioned, when does that go live? And he replied to me that it's July 2022. So happy to talk more about that, but at least that's a nice quick answer of, I'm sure, a lot of work that's happening. And I tagged a lot of questions. There's certainly some about schooling and education. So Cheryl, we can keep you up, and others, please jump in. Here we go. Okay, so I'm gonna, maybe these might have some overlap. So I'm gonna say, will collaboration with schools happen at the state level through SELPAs, county level, at the local level, or all of the above? And then kind of a related one is grants to, and thank you, Dina Davis, and from Brenna Garcia, grants to schools need to inform the parent fully of what will be offered, why their child qualifies, communicate directly with a provider liaison potentially. And then my experience with schools is inequity among other issues. Love the 988 option. So let's start with those two, and then I'll queue up some others that I can bundle. Cheryl, do you feel like you want to start with that? Or Jim, is that something that you would want to? Or Kim? We got great people.
I'll just start by saying, I'll let Jim go. Go ahead, Jim.
No, go ahead, Cheryl.
No, I was just going to say, I think this is something that you can address too in terms of the state level. I think one of the things that is a problem is that and that's why I so appreciate this panel, is that we really do need to have, things moving up from the local level, county level, the SELPA level, the county level, and the state level, so that not only are we implementing all these changes, but we're actually monitoring whether they're being implemented with fidelity and whether they're working, and gathering data. And so I always say, there's developing a plan, and then there's implementing it. And there's some real challenges with that. So with that said, I'll leave it to you, Jim.
And the 988, for example, has a statewide advisory group that is providing input. And right now, if you have an AT&T or Verizon cell phone, though it hasn't been publicized, you can already dial 988 but you are connected to the National Suicide Crisis Line. And in some cases, that will be answered here in California through our Lifeline system. The evolution is going to help us make sure that it goes to the right Lifeline center. So right now, if you are like me and your cell phone number is where you originally got it 25 years ago, it may not be physically located in that same area. But right now, the system sees you as where your phone number is registered, not where you are physically located. So we're trying to update technology to geolocate where the actual phone is, rather than the area code that the number was originally registered with. So there's a number of evolutions and things being done behind the scenes to make the system work more effectively.
Okay, anyone else want to jump in about that? Because we have so many others and we only have like 2 minutes. There's some questions about transition. I'm gonna, if anyone wants to say very quickly of where other resources to find those things, there's a question about EPSDT and once the child turns 21, and then also some more about that sort of challenge. And then I have 2 more that I'm going to bundle. So any quick references, since we can't really get into too much detail for how, from a systemic level, we're trying to approach what I think a lot of parents feel like is just this huge cliff and clients, and then where people could go for resources.
Yeah, I mean, this is Kim, I'll quickly say, we would love EPSDT to be, available forever, as an entitlement. It unfortunately is not under the federal law available after a youth turns 21. However, mental health services are required as part of the essential health benefits under the Affordable Care Act for adults, as well as substance use disorder services. And there are a whole variety of services available through both the health plan and the mental health plans to obtain. They just don't have the robustness of some of the EPSDT specific services that we have been able to gain here and in other states through that entitlement itself. So I wouldn't say just that you should feel despair, but you should be planning ahead for how to continue those services and try to ensure that that ongoing availability of support can be provided in different ways through the mental health services and some of the services that the plans can be providing, like enhanced care management, which continues through to adults. So
and I just want to tag on to that quickly and say that's one of the reasons why we really encourage families who have youth that are at transition age to attend trainings and talk to us and get involved in that process really early, because there's assessment and data that can be done in those last year or 2 of school that can really drive a higher level and more appropriate services. But there's waiting lists for services, there's service coordination with Department of Rehab and Regional Center and so on. And so the sooner the better.
Okay, and then I am going to just point out something that clearly has a lot of interest that I think we're going to have to carve out a whole nother topic around, maybe something as a single topic between now and then, which is capacity. A lot of people are asking about how can we train more people? What are strategies in place to increase and retain mental health providers? Sarah Taylor put a wonderful comment in the Q&A that hopefully people can all access about some of the work that she's doing as part of Cal State East Bay and some work she's involved in, but also some of the challenges. So unfortunately, we're going to have to pin that, whatever that expression is, pin that, put it in the parking lot is a whole nother thing. But
and can I just mention
yeah,
quickly, one service that hasn't been mentioned that's also coming online is community health workers as a benefit. That in addition to the peer support services, doula care, all of these are sort of what I consider like paraprofessional service opportunities to provide services through non-clinical and non-licensed staff. So I think this is where we need to be thinking about and going in terms of lived experience in the system and what those professionals, as I call them, or experts can offer in the array of services that we need to build while we're trying to gear up to get more licensed staff, which takes a lot longer.
Yeah, and Kim, I would just add to that in IEP meetings and 504 meetings that I've attended in really high risk situations with foster youth and families who are really in crisis, what you see is when there is a family partner or someone from county mental health who's doing that kind of coordination, who can attend, and it's an issue because of time, it makes such a difference because of the kind of data and the way they help a parent translate what's happening at home into the language of education, which is such a barrier for so many families. So that's a great point.
So Pip is giving me the virtual hook. I'm afraid we're going to have to stop, although I would love to keep talking with all of you, and we have such great questions.
I just want to say, Anne, there's one parent who put a question in there about foster care, and I would just encourage them to call me or email me directly.
We're Family Voices. That's the great thing about the Q&A for everyone to keep in mind for the next rest of today and tomorrow, that retains. And so Family Voices will be able to go through the Q&A later to parse out, oh, this would be a great question for Cheryl or what have you. So please feel free, people, and to attendees, to put in the Q&A things, and we can connect folks, not in the pressure of real time. So thank you to all our panelists. It was, I think, just such a, there's so much going on. It is really exciting to hear about this lots of the under the iceberg that is a challenge, but that there's lots of poppies, lots of hope around what we can do to try to get both the bread and the roses supported in our beautiful state. Please check. The door prizes are listed for our winners in the chat. So maybe you're a lucky winner. I'll let you check it out for the suspense. Thank you all for attending. Special thanks to our panelists and our sponsors and tech support behind the scenes. The session will end momentarily and will all be directed back to the Whova main page before the next session, which begins at 11 a.m. So you got 10 minutes to do your bio break, get your coffee, settle your kids, switch TV stations, whatever, for your little guys. Click on the agenda from the home screen and select which session you'd like to view. And then we have an optional networking lunch that begins at 12 p.m. Click on that session on the agenda to go to a Zoom breakout room where you can talk to other attendees from your region. So I'll be popping in. Okay, thank you all so much. Yvette, thank you too for your fireside chat, and hopefully we'll all be seeing each other virtually in this next day or two.
Good job. Thank you.
Thank you.